on Zoom as well as in person. As a reminder, we are going to restart in-person conferences at all of the sites. Just a few rules that we want to review, and these rules are the same at all of the sites. So no more than 10 people in the room. Everyone in the room needs to have received their second COVID shot at least 2 weeks ago, so they're fully vaccinated. Still need to wear masks whenever you're not actively eating. And we'll try and mix it up so we have a different group every day. Let's see. So again, welcome back. For those of you in the room today, I'm going to kind of have you guys serve as our discussants. I might need to have you speak up and I can come around with my computer. Sneha and I have not mastered the technology at the U quite to the level that Corey and Danny had. So this case is going to be similar in style to what we did during a recruitment, another cold case, kind of working it through. The crux of this case is certainly the diagnosis. So let's get started. You get called with a one-liner from the ED. They have a 42-year-old gentleman coming in with 12 days of fever. So just, I think it's important to acknowledge the unconscious ways that we are approaching patients and try and make it a more of a conscious practice. So right away, I want you guys to start thinking about what's on your differential, what information do you need when you go in the room, and are there any things that you want before you get in the room? And because Meryl clearly has a thinking face on, what are you thinking, Meryl?
Yeah, I mean, I always have like my big three with fever, like infection, autoimmune, cancer.
Cool. I'm gonna have you speak up really loud.
Yeah, so I was thinking of my big three with fever, so just like super broad, autoimmune, infectious, cancer. He's like he's not young, but he's not really old either. He's a man, so I think all of those three things are possible.
Awesome.
Maybe like less autoimmune since he's a man. But 12 days is kind of like that subacute time course. And so
yeah,
thinking of like maybe less acute things and more subacute. So yeah, I want to ask about associated symptoms, travel, other sick people.
Perfect. Awesome. And yeah, so if anyone couldn't hear, big things with a fever in anyone really, autoimmune, infection, and cancer. And I think that's like exactly the keys right there. And then is there any information that you're going to want? Okay. And then is there any information that you guys are going to want before you go into the room, if possible, recognizing there might not, be anything back, but what is the stuff that you'd like to know if you could?
Is it vital signs? His other ones?
Yeah, the vital signs. So I'll tell you for him, he's afebrile. We'll get those in a while as well, but tachycardic to like the 120s. Normopressive, he was like 120 over 70s, and satting low 90s on room air.
Has medical history, recent travel.
Yeah, so there's nothing else in the chart for him. He doesn't look like he really has been seen here before.
What about any meds, like drug fever would also be on differential?
Yeah, but there's nothing in the chart because he's never been in the hospital before. But definitely we'll ask him when he gets there.
A basic set of labs and then like a COVID test.
Yeah, so this was pre-COVID, so there's no COVID. And then the labs aren't back yet.
This will be when we go in the room, but this is really obvious, but like, what does fever actually mean?
Yeah.
His report, has this been measured? And if it's been measured, are we talking about like 38.0 or like 40s? Because that changes your differential.
Absolutely. So talking about what is fever meaning for this patient? Do we have numbers? Do we have a thermometer? Is it 38 or is it 40? So you go in and you're chatting with this patient. So he says that he's had these fevers on and off for, he says, the past 12 days. He doesn't have a thermometer at home, but he's been diaphoretic with chills. He complains of a headache, cough, and congestion as well, with blurred vision in his left eye and dysuria. He says he doesn't have a PCP, has not seen a doctor really ever. He moved to the US about 30 years ago, speaks some English, but mainly Spanish speaking. And then he says he hasn't used Tylenol or NSAID since he was last seen in the ED. So what questions do you guys have now?
When was the last time he was in the ED?
Yeah, excellent question. So he was seen at another ED, different hospital, about 1 week ago.
For similar complaints? or-
So he says that time he went in with a headache that he'd had for 4 days. He's not sure exactly what they gave him, but he got something from an IV, medicine and fluids and a couple pills, felt better, and left.
Is he sexually active and or has he had a negative HIV test?
Yeah, great. So he does not know about HIV. He thinks they may have checked at the other hospital. He's actually active just with his wife. Excellent question. I think that's a really, really reasonable place to jump when you're getting this constellation of symptoms, worried about like a new presentation of HIV.
Or syphilis?
Or syphilis, yeah. And he also wasn't sure if that had been checked.
How long has this blurry vision been going on for?
Yeah, he can't say for sure. He feels like he had it when he went to the hospital last time, but it got better with the medicine that they gave him. Now it comes and it goes. It's definitely just in the left eye. It's not vision loss, it's more just things aren't as clear.
Any previous episodes prior to the last ED visit?
Any previous?
Episodes of this?
Oh yeah. So any previous feelings like this? No, he hasn't, like he really has not seen a doctor since he's lived in the US for the last 30 years. And then doesn't know when he was a kid if he saw doctors. Also doesn't know if he got vaccinations as a kid.
Does he have any pain behind this eye? Current headache, pain with moving the eye, anything like that?
Yeah, great question. So he says that he's not sure if the headache is related to the change in his vision, but he says, I think the headache kind of wraps all the way around his head. Not really, the headache doesn't seem to come and go and be worse when his vision is worse. But he doesn't usually have headaches. And before this visit to the ED last week, hadn't ever really had headaches in the past.
Does he have any like weakness or sensory changes?
Or what, sensory changes? Yeah, really good question. So he doesn't have weakness. He just feels really tired. He says he's felt really, really tired for at least the last 2 weeks. And he says he has pain in his feet that seems to be getting worse. That's been going on for a long time, but he's noticing it more now. He says like shooting pains in his feet. He doesn't admit to any sensory changes though.
Any history of like IV drug use?
No, so he no IV drug use ever, denies any marijuana, cocaine, smoking drugs either.
Any night sweats or weight loss?
Yeah, so no weight loss that he's noted. He definitely has had like more just diaphoresis with chills. And in terms of just getting to if there's a pattern to his fever, he really hasn't noticed one. He says that it comes and goes over the course of the day. He doesn't notice it more in the morning or the night. But today was just the first day off that he's had since he was here a week ago. And so that's why he came today. He doesn't necessarily feel much worse than he did in the last 2 or 3 days. This was just the only day he could come in.
You might have already described it, but the cough, is it productive, not productive? Is it really bothersome?
The cough is not as bothersome. He hasn't noticed that it's productive. That was just something that got picked up more on the review of systems.
Does he have TB?
TB. I know, right? Oh, I will say that from the initial suspicion is low. So yeah, I want to kind of throw in the 1 week ago ED visit because I think it's super helpful. Again, it was in another hospital, but That time again, he came in with 4 days of nausea and a headache. He said the headache was 9 out of 10, a constant pain at his temples that wrapped around the back of his head. He says that's how the headache feels now. It's more of like a 6 out of 10 though, and not his biggest concern. That time he was having photophobia in his left eye, but no real changes in vision. And he didn't have a history of migraines or headaches. Still hasn't developed that. And it didn't respond to Tylenol. The day he went to the ED, he had new nausea and emesis, no emesis, sorry, dry heaves only. He hadn't gotten a flu shot yet that year. This was January of like last year, so COVID wasn't a thing, and this is not COVID. Just to like avoid that. He's not taking any medications currently. He does generally drink coffee in the morning, but hadn't for the 4 days before his last presentation, and still hasn't when you're seeing him again. He just like doesn't feel good. When he was seen last time, he did have a fever to 38.4, tachycardic as he was this time to 102. Blood pressure was a little higher, 139 over 80s. Remember this time it's like 120s over 70s. Satting again like 94 on room air. Exam last time, he looked uncomfortable, moist mucous membranes, rapid rate, regular rhythm. His lungs were completely normal on exam, and really otherwise a non-focal exam. They did get a few labs a week ago, including a CBC with no diff, but it was completely normal. An INR and PT that were normal because they got an LP for these vision changes. As well as influenza and RSV. Really, all of those studies came back unremarkable, just notable for a glucose of 99 in the LP. And before the LP, they did a CT head that was also completely benign. Unfortunately, I don't have a ton of imaging for this case because a lot of the workup was done at an outside hospital. So, knowing this, are there other questions that we want to ask this gentleman? Yeah, this was the CT head number.
We may have already talked about this explicitly. But
Yeah.
No past medical history, he's not on any meds, nothing like that. Right?
No, yeah, he again like really hasn't seen a doctor at all. And this is what he got in the ED last week. So just like migraine cocktail, felt great, and a liter of fluid, felt great, went home. And per the note at the time, they were pretty worried about him. That's why they did the LP. It sounds like when he came in last week, he said, I don't have insurance. I want like as little as you could do. I just feel too sick to work. And they said, okay, we'll do all of this stuff. They followed up the LP culture that did not have any growth now a week later. And they said, you need to go to this PCP appointment in 3 days because we really want to make sure someone sees you. Unfortunately, he didn't have that day off and was unable to go. So he hadn't followed up despite good planning on the part of the providers.
Any recent travel?
No. So he, let's see. So here's kind of more history stuff. We've covered a lot of it, but he hasn't left the state for at least a couple years. The only family he's in contact with are his mother and brother, who are both healthy as far as he knows, don't take medicines as far as he knows. And then again, Spanish speaking, he's a never smoker, occasional alcohol, and works as a day laborer in construction. Any other questions before we go to see him? Okay, so in the room this time, again, of course, he doesn't have a fever, but I think fevers are difficult to track in a lot of ways, but he's tachycardic. And this is a repeat vital. His systolic is a little lower, like 112 over 70s, setting 90 on room air. On the exam, this is just what was documented from admission. His vision was grossly intact. That was all that was there. So I honestly can't comment more. He had a clear oropharynx, but dry mucous membranes. No retractions, but pretty diffusely coarse breath sounds. With a rapid rate, regular rhythm, good pulses, maybe a little bit sluggish cap refill. He was awake, alert, oriented, and his extremities were symmetric with normal range of motion. Admittedly, this was just kind of what was on the original exam, which is pretty brief. Are there other questions or other things that you'd like to know about?
Yeah, I want to do like a better eye exam.
Yeah,
Document it a little bit better.
absolutely.
I certainly don't.
I mean, I always feel like extraocular.
Like a neuro, like a quick
Yeah, a neuro.
Yeah.
Yeah, so like a quick neuro exam. His
I actually like to do the block the eye and like the quadrants.
Yeah, and so he does have his normal extraocular motion, but does seem to have just diminished, there's definitely diminished acuity on the left side. And it's hard to tell if there's also like a visual field cut on the initial exam at least, but he certainly like seems to notice your hand later and is frequently guessing the wrong number of fingers.
And there's no pain with moving his eye.
No.
Isn't that if you like a noting thing?
Yeah, great question. So there wasn't cervical adenopathy. Yeah. What are you thinking there?
Just like malignancy and like certain weird infections can give you lymph nodes.
Yeah, absolutely.
And then you know if the skin exam was like just visible or like they did a real skin exam?
I think it was just visible. Annie, what are you thinking there?
I mean, variety. I would want to know if you had a rash anywhere, so I'd want to do like a more thorough skin exam.
Yeah, absolutely. I think that's super reasonable. Someone somewhere early in the admission asked about rashes, recent rashes, and he said he hadn't noticed any. And then I will say, not initially, but within the first couple of days of hospitalization, we got a pretty thorough neuro exam that had diminished sensation to light touch and vibration in the bilateral lower extremities up to about the knee. So before we go on and start getting labs and imaging back, Dr. Eller, thank you. Yes, I was hoping someone would comment on that. So the SpO2 is of 90% is abnormal, particularly with a respiration rate of 28. Absolutely. I think we can get a little nerd or become less conscious of the O2 level in Denver. Because no one is going to be, well, we're accepting a few people being 100%. And when he was seen at the outside hospital last week, he was in the 90s, or like 94 on room air with a normal respiratory rate. But now we're seeing him and he's dropped down. And although he's more tachypnic, he's still hypoxic. So I think that is something to certainly put on our radar and make us maybe worry more about this cough or worry more about some other processes going on. So I think this is like part of the reason I chose this guy is he's a challenging presentation between being Spanish speaking, not having healthcare, being seen briefly at another hospital, but really not having an excellent story. I think he's challenging to put together. And it's important to not be overly frustrated by that and instead just kind of say like, what do we have? What do we know? And what do we want to do next? Before I show you my problem representation, what would you guys describe like this gentleman's one-liner as?
42-year-old male, no significant past medical history, presents with subacute fevers, headache, blurry vision, concerning for underlying infection versus autoimmune versus malignancy.
Excellent. Perfect. And that's like pretty much exactly what I had. I think I'm maybe guiding you a little bit, that this is certainly, based on what we're seeing, seems most likely infection. He wasn't having weight loss or night sweats or and didn't have a strong history of autoimmune, but I think the autoimmune and cancer are still high on our differential until we get at least some labs back. So what do you guys want to get on this, gentleman? I have a lot that we know about. There's only a few on the slide, but I'll tell you as much as I do know.
Blood cultures.
Blood cultures, yes.
In those labs that you showed us before, that was from the other hospital?
Yeah, so, and that was all they got. So just as a reminder, what we know so far is he had a CBC that was completely within normal limits. There was no diff, and a INRPT that was normal, as well as an LP with elevated glucose. And that was all cultures that a week later still have no growth.
So looking at a repeat CBC with a diff, with a CMP,
Mhm.
kind of A1C, why was his glucose high?
Yeah.
CSF. Yeah, I might get A1C.
A1C, great.
HIV, RPR.
RPR, HIV, perfect.
When they did the CT, sorry, would it have contrast on it?
No. CT with contrast?
Yeah, I wonder if something like CT sinuses or CT with contrast.
Yeah, absolutely. We're gonna skip that. Okay, so these are his labs.
That's different.
Let's go lactate.
Yeah. I put that in there because I do think like this is like a couple points here of like he did not look as sick as these labs would indicate.
Oh, his glucose is pretty high.
Yeah.
Yeah.
Yeah, exactly. I think this was a surprise to everyone when it came back. And these actually were the reason that he was getting admitted, because he was far sicker than just a gentleman coming in with weeks of maybe subjective fevers. So here we talked about like he's hyponatremic. It does correct to like 131, so it's a very mild hyponatremia. The potassium is also low, just not red.
Sorry, he wasn't a drinker, you said?
No.
Okay.
And yeah, he's got some mild abnormalities in his LFTs, really impressive leukocytosis. And then I'll tell you for the ones that are back so far, A1C is pending. It comes back like pretty quickly though. It was greater than 13. Then he had HIV was negative, RPR was negative. What else did you guys want that was?
Did he get like a HEP panel, like a Hep C?
After this he did, and those all came back negative. Blood cultures are still pending.
So even just knowing he's diabetic, we're learning that he's more immunocompromised than we would imagine. So definitely the fear for cold infection is higher.
Absolutely. So kind of, I think this is a person where it's really helpful to break it down by like, what's going on and what do we need to do for him? So I will tell you the slides. Let me see if this slide is the right one. Okay, so here's the chest x-ray, which is the next thing we get back. You guys a bit to look at it. Anything jumping out?
I got bilateral infusion.
Yeah.
There's a little bit of consolidation on that.
Yeah, absolutely. Yeah. But not, I would say the bilateral effusions, probably consolidation versus pneumonia. So maybe we've got a source here. So I'm going to go back to the labs and knowing what we know with the chest x-ray and his story, what would we put as his first problem?
Sepsis.
Yeah, exactly. Like, I think it's safe to say from everything we know right now, this is sepsis. Seemingly pulmonary source, or possible pulmonary source. At least there's pulmonary involvement. And so what do we want to do for that?
Start him on antibiotics.
Yeah, what antibiotics?
I mean, if we're concerned about pneumonia, I would start with like a cap coverage, so ceftriaxone and azithro.
I think that's reasonable, and that's what he got started on. I think there's also potentially an argument to be made to at least think about pseudomonal coverage, just because he has this pretty significant elevation in his glucose and untreated diabetes. I think in talking with him, it sounds like he, again, not only had not seen doctors, but like hadn't been in a hospital or near anyone. So I agree that I think cap coverage was probably the best place to start. So he has a whole host of other problems. What would you say is the next biggest problem right now? Yeah, I think that's pretty reasonable. Why do we think he probably has an AKI?
Maybe it's like sepsis, like an organ damage.
Yeah,
He's probably losing so much volume with his elevated glucose.
exactly. Yeah, like the two hits of like an osmotic diuresis plus feeling crummy. So I'm just going to push you a little bit because I think we always rely on the protocols. So for we're going to give him fluids for his AKI. And then for this next problem of DKA, HHS, somewhere in there with osmotic diuresis, how do we want to approach that? What do we want to do there?
We need to replace potassium.
Yes, love lots of potassium. I think as much potassium as we can get him in IV. And he's nauseous already, so probably not a ton oral, but try to replete that. Great. And we're already giving him fluids for sepsis. Do we think he's going to need even more fluids, or should the sepsis 30 cc's per kg be enough?
He's more fluids. Yeah.
Yeah, absolutely. I think just hitting home that like DKA, HHS are osmotic diuresis processes, and fluids will often correct these folks a good degree of the way.
Could you get a lactate? I'm just curious how much of this is his DKA versus sepsis.
Absolutely. I think the initial lactate was about, it's like 7.
7.
Yeah. So not great, but not terrifying.
Did you guys get a beta hydroxybutyrate on him? Or?
We did. It was a bajillion.
Okay.
It was a
I mean,
lot.
yeah, I
It
would
was
treat
like
this
90.
more of DKA versus an HHS.
Yeah, because the glucose isn't
Yeah.
that high.
Yeah.
Exactly. Perfect. Okay, and then what about do we want to do anything for the LFTs? And what about that elevated hemoglobin and elevated platelets?
I mean, that's a pretty high hemoglobin, but it's not
It's like
unreasonable to think, yeah, it's just hemoconcentrated,
Mhm.
especially since like all the lines are up. And then certainly platelets, you just get acute vasoreactant, but they're all pretty up, so feel a little less, I'd maybe like see if it corrects after it gets all the fluids.
Perfect.
LFTs, I don't know.
Oh, you can get a right upper quadrant. I mean, like
Yeah.
with his elevated T-belly, I mean, maybe we suspect his infection is from the pneumonia, but was he having abdominal pain?
So now it's kind of like the abdominal pain, nausea. He's not having focal like right upper quadrant. pain
Okay,
now.
because
Yeah.
that's like also different, just like cholangitis or like a cholecystitis.
Absolutely, but I think it's probably reasonable to try and image the lungs. And then, so the thought at this point was, between the fact that he's got what look like he's got effusions and we want to see like how sucked in that pneumonia is in the lower lobes, as well as the liver. They went with a CT just to get both and image them well. And you can always do the right upper quadrant ultrasound, especially knowing that he can't really get contrast. So he got a CT head and neck as well because of the vision changes. And even there, they were able to see multiple solid and subsolid nodules in the bilateral apices, concerning for septic emboli. And they weren't really visible in the chest x-ray going back at all. I think they were small enough. Unfortunately, I don't have the CT. And so he did get MRI brain without contrast, again, with this concern with the vision, showing new multiple punctate. Well, I guess we don't know for certain because it was a CT non-con last time, but seemingly new punctate bilateral frontoparietal and left temporal subacute infarctions, also likely embolic. And then, so he got a CT that was significant for abscesses in the liver. And then the pneumonia and the bilateral bases appeared to be more of an embolic phenomenon as well. So, and his blood cultures very quickly came back with Klebsiella pneumonia. So, yes, exactly. So tell me why is Klebsiella pneumonia? Oh, perfect. Thank you, Dr. Albert. So other infections to think about always with uncontrolled diabetes is mucor. And so someone fortunately did go back in this gentleman and do a really good oral exam. And there were no Eschers or oral lesions. And the sinuses didn't have evidence of invasive disease. But Ariana, tell me, like, you're just like Klebsiella pneumonia. This is weird. Why is it so weird?
Well, it's usually like an enteric sores.
Yeah.
And it would like to have like brain infarctions, which could be like septic emboli. It would be really weird to have like an endocarditis source if that's what it's coming from, presumably to be Klebsiella.
Excellent. So just in case you couldn't hear, Ariana picked immediately up on exactly the weirdness of this, of a gentleman who has like a Klebsiella pneumonia with evidence of other embolic phenomenon. You don't so he's seemingly bacteremic with Klebsiella from an enteric source, but we don't have a great source. And Klebsiella is not really fond of heart valves. But again, because he was bacteremic, he did get a TTE. That was clean. There's always an element of hedging, but less than usual. So yeah, exactly. They weren't going to say it was definitely not endocarditis, but the valves were pretty clean, good function. And I will say this gentleman continued to be bacteremic. So they were trying, and he did have liver abscesses. He got percutaneous tubes to drain those. But there was one, and this is a little bit of a trick. It was something that was quickly overlooked because he did come in with so many symptoms, but he was complaining about dysuria when he came in. He got a urine that was a little bit dirty, but difficult to evaluate because it had the protein, the ketones, definitely had leucine, nitrites, it had everything in it. But one thing that was not done in this gentleman until he got a CT abdomen pelvis was a prostate exam. And he had a very tender, boggy prostate. And so this was ultimately Klebsiella prostatitis that in the setting of his diabetes became disseminated and led to this disseminated infection. Fortunately, following a therapeutic TERP, he did improve significantly and even recovered the majority of the vision in his left eye. But
Wait, the septic emboli were from what?
bacteremia from the Klebsiella. Yeah, and they think it was just, there was such a high bacterial burden. Because, and it's unclear. I think the thing I would love to know what his BMP was at the week before he came in. But I honestly think it probably would have been pretty normal. Because I don't think he wasn't in DKA for a week before he came in. And I've like wondered this many times of like, would having a BMP from the week before change anything about this course?
I wonder if like after he probably got initial antibiotics with like ceftriaxone, if his dysuria improved and so he wasn't complaining of those symptoms anymore, and that's probably why no one looked into like a prostate exam after that.
I think so, because it was, and I think it was,
Well,
yeah.
And also prostatitis, don't they? Well, I guess you worry about seeding, but like I guess he's already seeded, so it doesn't matter.
Yeah.
But
Yeah.
Yeah.
I think so.
And they saw something on imaging that made them think.
Yeah, finally he got another before he'd had a CT chest and abdomen without necessarily like full pelvis. And they were finally like, he kept coming back bacteremic and they could not identify a source. So he got the full pan-man scan and there was a prostatic abscess.
Did he complain of urinary retention and?
He didn't, and he really only, looking through the notes, mentioned dysuria to maybe 1 to 2 providers, which I think also speaks to like a gentleman unfamiliar or uncomfortable in the healthcare setting mentioning like a more sensitive complaint. I think it was truly like felt uncomfortable talking about it. And then I think you're right on that he probably got some antibiotics and the dysuria went away, and or he'd been dealing with it for long enough that he was like, meh, compared to everything else, this isn't a problem. But I think just a really impressive example of how infections can run rampant in people with untreated diabetes. And I think making sure that you're really systematic about, at least for whatever a patient brings up to you, having an idea of what could be causing it. Again, he was tricky because looking back, someone in the initial either H&P or progress note, like the first day, mentioned the dysuria again and said like UA was so pan positive, and we'll follow up the cultures. And the cultures came back with had too many species that they thought it was just a contaminant. Fortunately though, we got him better. And I think as of at least a few months ago, he was still following up and his A1C was significantly improved, like 8. Yeah, it really was awesome. But I think, yeah, just making sure you think about infection and anyone coming in with this.
So was the blurry vision from the septic Amelia? Okay, it wasn't because of diabetes.
Yeah, fortunately, that'll come soon.
Because that would be weird for it to be one eye, right?
Yeah.
It would be bilateral. If it was from diabetes.
Unless you were having like retinopathy, sometimes you can get it.
Mhm.
Asymmetrical.
Yeah, it did improve pretty quickly, but awesome. Thanks, guys. Importantly, in this case, gram-positive and negative bacteremia aren't thought about in the same way. That's true. Yeah, thanks. Absolutely, Chris. So we don't always, with gram-negative bacteremia, do repeat cultures. We assume it should resolve quickly with antibiotics. He kept fevering, and that was why he continued to get cultures.
Did he get like a longer course of antibiotics with his gram-negative? Because isn't it usually they say like 7 to 14 days? Everyone is at a 7 with gram-negative.
Yeah, and so he definitely got towards the 14 days after the TERP. So like he finally got the TERP, cleared out the infection, and the cultures grew tons of Klebsiella instantaneously. And then it was 14 days from then.
Okay.
Yeah.
You got like source control.
Mhm. Yeah, great point.
Yeah, and like what I'm kind of referring to too is that with gram-negative bacteremia, you don't worry so much about the bacteremia. It's a tip off to you that there's a source somewhere that you need to find. Whereas with gram-positive bacteremia, that in and of itself changes what your treatment duration is. You have to do surveillance cultures, and it's kind of endocarditis until proven otherwise. Like you've got to find another source and rule out endocarditis. So it's a very different both diagnostic workup and therapeutic response for when you go to GP, gram positives instead of negatives.
Great. Thank you, Chris. Yeah. And then another thing to think about is diabetes causing dehydration with a venous thrombus and septic phlebitis as a cause of recurrent bacteremia and seeing the prostate. Any suggestions of phlebitis or history of PEs? So he never had phlebitis while he was there, and no PE. He did get CTs. He never got contrast, but he was no significant suspicion of PE. I guess later, towards the end of his hospitalization, he may have gotten a CT PE looking for that with that thought exactly, and there wasn't any evidence of it. Awesome. Thanks, guys. Yeah. Of course you like it. Awesome. Thank you, guys. On feed. Gotcha. Oh, okay. On exam. Yeah, no, so he didn't have phlebitis on exam that was documented ever.
Chris, will you stay on for a second?
I'm wondering if I should call into the central.
Yeah, let's see if I can.
Mics hanging off.
Yeah.
Then maybe we can just like disperse.
Yeah, I think so. I realized that exactly at 12:05 and I was like,
Yeah.
I can get you those.
I don't know, I haven't heard anything yet. How does that work for Med 2? Does do you get paid? Does your attending get paid?
Because the hospital and procedures, you don't get the first pages, and so if you want them, you come after you have them.
And I also just like
I thought
anytime I
they-
saw
thought
other
they
teams, it would be
triage
like.
them Or whatever.
Because the week I was on, it was like holiday coverage, it was me as an intern,
Uh-huh.
and so because it was me as an intern, we didn't have like a ton of like extra capacity to, and we were capped. It's
Yeah,
hard to like have time to do procedures, we only did a couple.
All
yeah.
right, let me, I was gonna tell you Sneha, but if you're good.
I would just text the hospital.
The
I think just
procedural
9.
hospitals? Okay,
Because I think the pages usually go to them.
okay,
Yeah.
okay.
Unless you're attending something.
No, I know, actually, I didn't ask him exclusively, so sounds good. I requested to be on this team because I wanted to be on.
Yeah, if you want procedures, you just have to like, ask them. Otherwise I don't know that they'll automatically come to you.
Okay, I'll message the, whatever, the procedural.
Yeah, when I did too, I would like, just anytime I saw the other teams, be like, do you guys have procedures you need? Let us know.
Mhm. Got it, okay. Thank you. Oh, are you pre-call or?
Yeah.
Okay, that's kind of nice. Yeah, yeah. Do how many patients do you have?
Two of them are like, one's already and one's like outside ready.
Oh, that's nice. Yeah, that's nice. So going into like your holiday with, you know,
Yeah.
no patients.
Yeah.
Yeah, it was fun. Yeah.
The subscriber you have dialed is not in service.
It was
Hmm.
Alan's part. It's like Alan's part. It was beautiful. It was just fun. It's like, well, we're seeing on Saturday, but then that night was oh my god. It was very early. Yeah. So, yeah. No, the one thing yeah. Oh, yeah. It's kind of like, I'd like to see Bob Blanchard. Oh,
Yeah, so I like, can try like a 9-1. 699-900-6833. Wanna try that one?
Yeah.
Okay, 9-1-253-215-872. Okay, so let's make Corey tell us how to do this. Cool. Hey, Chris, you can head out. We're not technology savvy enough. We're gonna make other folks do it.
Okay, sounds good.
Thank you.
Bye.
Thank you.
I know, that's so weird. I'm trying to remember, I haven't